Good morning. Hepatitis C virus infection in the kidney. It is a very interesting and important topic in nephrology. The issue of seminars in dialysis March and April this year focused on hepatitis C virus infection in patients with kidney diseases and considered a roadmap for nephrologists. This stimulated us to deliver an interactive session about HCV and the kidney in more than 1 hour and 40 minutes. And today, this is the highlight of the summary of this interactive session. And today I'm happy to have Dr. Muhammed Elhadedy and Dr. Ahmed Yahia from the nephrology unit at Urology and Nephro Center, who will give us the juice of hepatitis C and the kidney. Dr. Elhadedy, you are welcome.
Regarding the algorithm for screening of HCV among dialysis patients, on admission of the patients to the dialysis facility, laboratory test including HCV antibody and liver enzymes is done. If the HCV antibody test is negative, then we should repeat the HCV antibody test every 6 months and the liver enzymes test monthly. And in case of the rise of the liver enzymes at any time, we must repeat the HCV antibody test. But if the result of the HCV antibody test is positive, then we must perform the HCV PCR. If the result is positive, we treat the patient with direct antiviral acting drugs, and if the result is negative, we monitor the patient and follow up the liver enzymes every month. In case of rise of the liver enzymes for any reason, we should repeat the HCV PCR test. Regarding evaluation of the CKD and end-stage renal disease patients with hepatitis C infection, the laboratory blood test includes either general test for liver disease, HCV specific test, or test for HIV and hepatitis B. The general test for liver disease including the liver enzymes, ALT, AST, also alkaline phosphatase and gamma glutamyl transferase. The HCV specific test include the hepatitis C virus antibody, and in case if the result is positive, an HCV PCR test is a must. Because of the overlapping of hepatitis B with the hepatitis C, we must exclude the presence of hepatitis B virus. Also because after the treatment of the hepatitis C patients with DAA, there are many studies which reported flaring of the hepatitis B virus. Then we must do HIV antibody test and hepatitis B core antibody, surface antigen, and surface antibody. The imaging studies modalities include the ultrasound and Doppler ultrasound, which are the gold standard diagnostic imaging modality. And in case of suspicion of carcinoma, then we proceed for doing non-contrast CT and MRI. Regarding the liver fibrosis assessment, for many years, liver biopsy has been considered as a gold standard method for assessment of the liver fibrosis. Two main staging systems were used, the Metafair staging system, which consists of 4 stages, and this Ishaq staging system, which consists of 6 stages. Now, the liver biopsy has been replaced by elastography techniques. The most important one is FibroScan, which consists of 4 stages from F0 to F4. In case of the patient, FibroScan result revealed F4, then we should perform hepatic venous pressure gradient in order to ensure whether the patient will have simultaneous liver and kidney transplantation, or we will just stick with the direct acting antiviral treatment. The algorithm on how to investigate an outbreak of hepatitis C virus infection in a dialysis facility. If a new HCV infection identified either through screening or abnormal labs, then we should review and confirm testing results, order HCV RNA test, notify medical director, notify patients, and arrange for patients to be further evaluated for HCV treatment. We must notify the local health department and follow the local guidance. We also must review the patient chart and interview the patients for hepatitis C virus traditional risk factors, healthcare exposures, consider potential for HCV acquisition outside of the dialysis facility. If the transmission could have occurred at the facility, we must do a thorough investigation at the clinic. We also must involve the local public health agency. We must review the HCV testing results of all patients in a facility in order to identify any additional new HCV cases and all known HCV patients. We reviewed patient seeding assignment in order to see if new HCV cases were in close proximity to other known HCV cases. This might suggest potential transmission pattern. We must consider HCV molecular testing in order to identify transmission in consultation with the local health department and CDC. Increasing the HCV screening frequency to either 1 every month or every 3 months for a period of 6 months after the last new HCV case is very important. We should inform the patients of the reason for why we increased the screening frequency. Reviewing the infection control practice, including hand hygiene, glove use, medication preparation and administration, vascular access care, cleaning and disinfection is very important. We also should address any gaps in infection control, increase the frequency of auditing and feedback in order to improve the infection control practice. We should consider an external observer or infection control consultant in order to conduct observations and provide recommendations to address gaps.
Thank you very much, Dr. Elhadedy, for this very interesting algorithms for diagnosis. Now we are going to shift on the use of direct-acting antiviral medications for treating hepatitis C virus infection with different grades of kidney functions. So I'm very happy to invite Dr. Ahmed Yahia to discuss this issue of the presentation. Dr. Yahia.
Regarding direct-acting antivirals used for treatment of HCV, this table will illustrate the different direct antiviral regimens can be used, their availability in Egypt, their price, and the doses for the patient with estimated GFR above 60 ml per minute. Sofosbuvir, named in the market Sovaldi, each tablet contains 400 mg of sofosbuvir to be taken once daily. Sofosbuvir plus vilpatasvir in the market is named Epiclusa or New Harmony, but it is not available in Egypt. Each tablet contains 400 mg of sofosbuvir plus 100 mg of vilpatasvir to be taken once daily. Sofosbuvir, vilpatasvir, voxilaprevir in the market is named Vosivi. Each tablet contains 400 mg of sofosbuvir, 100 mg of vilpatasvir, 100 mg of voxilaprevir to be taken once daily. Glicaprevir plus piprantasvir in the market is named Maviret. It is not available in Egypt. Each tablet contains 100 mg of glicaprevir plus 40 mg of piprantasvir to be taken 3 tablets once daily. Sofosbuvir plus lidibasvir. Its name in the market is Harmony and it is available in Egypt. 400 mg of sofosbuvir plus 90 mg of lidibasvir to be taken once daily. Paritabravir, ompitassevir, ritonavir in Egypt is named Curivo, and each tablet contains 75 mg of paritabravir, 12.5 mg of ompitassevir, plus 50 mg of ritonavir to be taken 2 tablets once daily. Paritabravir, ompitassevir, ritonavir plus dasapuvir, Vicera. It is not available in Egypt. Each tablet contains 75 mg of paritabravir, 12.5 mg of ompitassevir, 50 mg of ritonavir plus 250 mg of dasapuvir, 2 tablets once daily. Grazoprevir plus elpasvir in Egypt is named Zipater. Each tablet contains 100 mg of grazoprevir plus 50 mg of elpasvir to be taken once daily also. This table shows the metabolic pathway of each direct-acting antiviral. Sofosbuvir has mainly renal excretion, so it is contraindicated in patients with creatinine clearance less than 30 ml per minute. Simpirivir, lidapasvir, vilpatasvir, daclatasvir with hepatic excretion are not contraindicated per se for patients with creatinine clearance less than 30 ml per minute, but they have to be combined with sofosbuvir. Paritaprevir, ritonavir, ompidacivir, dasapuvir regimen, Graspoprevir, Elpasivir regimen, Glicaprevir, Piprantasivir regimen, all have hepatic excretion pathway, and they are all not restricted to CKD or end-stage renal disease patient. So, EDIL guidelines 2018 and KDIGO guidelines 2019 recommended the use of one of the following regimens for patients with creatinine clearance less than 30 ml per minute: Paritaprevir, ritonavir, ompidacivir, Paritaprevir, ritonavir, ompidacivir plus dasapuvir, Elpasivir, Graspoprevir, Glicaprevir plus Piprantasivir. Deep gratitude to Dr. Shuruk for summarizing the hepatitis C treatment protocol in Egypt, established by the Egyptian National Committee for Control of Viral Hepatitis and based on the EDIL guidelines. If the patient have compensated cirrhosis, either with normal GFR or CKD stage 1 or 2 or 3 with estimated GFR above 30 ml per minute, the patient is considered easy to treat patient if he is naive and didn't experience interferon therapy before, total bilirubin less than 1.2 mg per deciliter, serum albumin above 3.5 gram per deciliter, platelet count more than 150,000 per millimeter cubic, or INR less than 1.2. In this case, the patient can receive 12-week regimen of sofosbuvir plus daclatasivir, or 12-week regimen of paritaprevir, ritonavir, ompidacivir. The patient is considered difficult to treat patient if he experienced it before interferon therapy or total protein above 1.2 mg per deciliter, serum albumin less than 3.5 gram per deciliter, platelet count less than 150 per millimeter cubic, or INR above 1.2. In such case, he can receive 12-week regimen of sofosbuvir, daclatasivir plus ribavirin. If the patient has compensated cirrhosis with estimated eGFR less than 30 ml per minute, CKD stage 4 or 5, provided that there are no evidence of cirrhosis, hemoglobin above 10 gram per deciliter, no associated uncontrolled comorbidities. In such a case, the patient can proceed for 12-week regimen of paritaprevir, ompidacivir plus ritonavir. In case of decompensated cirrhosis, if the patient has normal GFR or GFR above 30 ml per minute, CKD stage 1 or 2 or 3, he can receive 24-week regimen of sofosbuvir, lidipasivir, or sofosbuvir, daclatasivir, or sofosbuvir, velpatasivir plus or minus ribavirin if he can tolerate ribavirin. But if the patient has decompensated cirrhosis with GFR less than 30 ml per minute, in such case, no regimen has been adopted for these cases till now. In case of relapse after sofosbuvir regimen, the patient can receive 24-week regimen of sofosbuvir, lidipasivir, sofosbuvir, daclatasivir, sofosbuvir, velpatasivir plus or minus ribavirin.
Thank you very much, Dr. Ahmed, for this summary. And now we are proceeding to transplantation. So clinical strategies for hepatitis C virus infected indecisional disease patients in the issue of thinking of transplantation. Dr. Elhadedy.
If the end-stage renal disease patients have a positive HCV antibody and positive HCV PCR test, and he is not a kidney transplant candidate, then we can consider DEA if the life expectancy is more than 12 months. But on the other hand, if he is considered a potential kidney transplant candidate, then we should proceed for non-invasive evaluation of the liver injury, which might show either a stage of 0 to 3 fibrosis or stage 4 fibrosis. In case of stage of 0 to 3 fibrosis and the potential donor is a living donor, then we can transplant with an HCV negative living donor with DEA prior to transplant. But if the donor is deceased donor, then we can either transplant with HCV negative kidney or transplant with HCV positive kidney, and in either way, the patient must receive DEA after the transplantation. But if the patient has stage 4 fibrosis with evidence for cirrhosis and portal hypertension represented in either liver biopsy, hepatic portal venous gradient more than 12, synthetic dysfunction, or esophageal varices. If any one of them is present, then we can consider simultaneous liver and kidney transplant. But if these evidence for cirrhosis and portal hypertension are absent, then we can transplant with HCV negative kidney with DAA prior to transplant, or we can transplant with HCV positive kidney with DAA after transplantation.
Regarding treatment of hepatitis C infection among kidney transplant recipients, in case of estimated GFR above 30 milli per minute, we can use 24-week regimen of fixed dose combination of sofosbuvir, leterpastevir for genotypes 1, 4, 5, and 6, or fixed dose combination of sofosbuvir and vilpatasvir for all genotypes. If the patient estimated GFR less than 30 milli per minute, they recommended fixed dose combination of glycaprevir and pibrentasvir for 12 weeks. Thank you.
At the end of this very nice algorithms prepared by Dr. Muhammed Elhadedy and Dr. Ahmed Yahia, thank you very much. I appreciate this effort, and I hope that this small work will lead to a positive effect in treating our patients. Thank you very much. Goodbye.